couldn't hear anything. Oh, perfect.
Good afternoon, everyone. Yes, Dr. Coupe, good afternoon. We're waiting for you, and I was waiting for the host on mutiny. For those of us who are on, good afternoon and welcome again to Let's Talk NMB. The reason we have decided just to employ some additional measures to make sure that we don't have folks who are coming onto a forum that is well intentioned, and for folks who are doing something that is ill intentioned to bomb and do something with the efforts that we're trying. So what is happening is that we mute everyone as they come on, and then the host, when she recognizes a thumbs up or someone wants to speak and all is clear, then she unmutes you. And this is just to stop what has happened on this and what happens in other forums where people get an opportunity just to jump in and to do unsavory things. Dr. Coupe, welcome. Welcome. You're probably one of the busiest persons that I've had to get a hold of. But I welcome you here today. I know you're a busy man, and I know we do appreciate you being here with us for the 30 minutes that it's going to take for us to get just a little piece of you, so to speak. So I'd like to will you just tell us who's Sidney Coupe?
Well, first of all, Mr. Scott, thank you so much for the invitation. I think this is a great initiative that your city is doing, and communicating and educating as much as we can is important. I don't like to use the word busy. I'm actually very committed instead. I'm a committed individual. I think busy is a story, and I think we can always have time to do the right thing. So I'll tell you a little bit more about me. I'm an internal medicine physician, and I've trained in Pennsylvania. Did my fellowship at University of Michigan, and since I've been here about 7 years now in Florida, and I've been practicing internal medicine as well as hospital medicine. We started an organization in 2005 called Spark Health. Spark Health is an organization that connects people to quality healthcare services in their community. And the way we do that is we started a community health clinic, so to speak. The first flagship community health clinic under Spark Health is Coupe Quality Clinic. It's the one that you guys all heard of, that's located here in South Florida. And what we do in this clinic is that we provide a comprehensive service to our community. Comprehensive from primary care to chronic disease management, behavioral health, as well as wellness. And we believe that to be appropriate, we have to provide comprehensive care. We don't believe care is in isolation. And so our community obviously points that to us clearly. And so we needed to respond. And so we provide this comprehensive service using a model that addresses access, quality, and costs. I don't know if anyone have heard of direct primary care, but it is a membership style program that allows people to access this amazing health service that we're providing, whether you have insurance or not, whether you're documented or not, and to be honest, if you're having financial difficulties, this is a great program to be in, very cost effective. So we're giving people in our community access to care using that model. So it's been very effective, and a lot of people are receiving the services that we've intended to give. So I think that is who I am in a nutshell, and what I've been doing in the community for about 7 years. And as you can imagine, from a pragmatic standpoint, I take care of people in the office. So I do the chronic disease management. I provide primary care. I function as an extensivist doctor. So I manage people with complex diseases and diseases that are very uncontrolled, and I get them under control. In addition, I also see patients in the hospital setting. So I practice acute medicine. And so my patients that end up being in the hospital, that get admitted, I'm the doctor that admits them, take care of them. And so as you can imagine, since this COVID-19 pandemic started, we've certainly been in the front lines of addressing the needs of our community.
And in seeing those, Dr. Coupe, what do you view to be the needs of the community right now?
Wow. Well, that's a loaded question, I have to
Very
say.
broad. Yes.
Yeah, because one of the things is, and I apologize for the disconnection there. Give me 1 second. I just want to make sure that we're on. Okay. All right.
You're good
Am I back?
now. You're good.
Okay, perfect. So essentially, our needs actually has evolved since this
Yes.
pandemic. Ever since as early as January, when we heard about the outbreak that happened in Wuhan, China, we knew what this meant for us. We knew what this meant for our community, and we needed to steadfast, and we needed to not only continue the work that we're doing, but actually enhance.
How did you let me just if I may just break in a little bit. I mean, when you say that you knew what it meant for our community, what do you mean by that?
So, we know what viruses really essentially do. And in fact, we know a lot about coronavirus. As you know, Mr. Scott, this is not the first time we are addressing a coronavirus outbreak. In fact, I'm sure you remember the SARS and the MERS. So now we have COVID-19, which we call the SARS-CoV-2. Again,
Yeah.
it's a type of coronavirus. And so when the outbreak happened, I immediately knew that there's a chance that this will hit us. And if it does, our community was at the highest risk for
Yes.
multiple, number one, because of exposure. And number two, knowing that if we're exposed to such virus, the complications will be harsh on our community than others, partly because there's already diseases that are disproportionately affecting us more so than any other communities. So that's what I mean by, I knew right away that we needed to create almost like hold up the front lines, create strategies
Yes.
that's effective in order to support the people in our community during this time.
And when you say our community, by that you mean?
Well, we and Mr. Scott, we live in a very diverse community here in South Florida.
Right.
We have Afro-Caribbeans, we have Latin Caribbean, we have all types of folks here. And more specifically, as you know, as the Black and brown people, whatever you want to call it, we are actually really represented majority here in South Florida. And so,
okay, so that's what you meant by community.
Yeah.
Okay, so knowing what this would its eventuality in this community, then as a physician, as an internist, what did you employ at that time?
So at that time, we knew that we had to employ a strategy that, number one, keeps us safe, meaning the providers, so the doctors, the nurses. In addition, we had to make sure that we had an education and communication campaign. Because as you know,
Yes.
When it comes to these pandemics, there's a lot of misinformation, rumors about what the disease is really about that could actually cost someone's life. So we knew education and communication was key in whatever model we create. Thirdly, we knew that we had to create innovation around caring for the people with chronic diseases, such as using telemedicine. We've been doing that in our practice for a very long time. And so picking that up was a little bit straightforward for us, and we had to enhance that. And also identify those meaning essential patients that needed to be seen that couldn't just be treated using telemedicine approach alone. And so, and what that means for them. And fourthly, we knew that we had to coordinate with laboratories and hospitals in our community. As people were leaving the hospitals, we had to make sure that we keep them out of the hospital, get appropriate handoff, make sure that the folks get their medications, make sure that no simple mishaps cause them to go back to the hospital. In addition to coordinate with the laboratory, sending obviously COVID-19 testing, really following up on those as well. So really, in a nutshell, we created a strategy which was four-prong approach, which is a primary care approach, which consists of safety protocols, number one. Number two, education communication campaign. So we educate every single one of our patients, as well as we took to social media, because we knew a lot of people in our community follow us on social media, and we educated using social media and all other outlets, media outlets. Number three, we did patient monitoring using telemedicine, as well as treatment obviously, for chronic disease management. And the last step, which is the fourth step, which is coordinate with the local hospitals and laboratories when it comes to making sure patients stay out of the hospital so we can help reduce the curve.
Right. Tell me a little bit more about, without blowing my mind here, about telemedicine, because it sounds very, very interesting.
I think the word is more sexy than actually the practicality of it.
Is that calling them on the telephone?
Absolutely, absolutely. And if we use smoke signals, I would have done that too.
Okay.
Oh yeah, absolutely. Whatever means it's for me to communicate with my patient, that's what I do. Not everyone has the ability to do FaceTime. Not everyone has the ability to get on their computers, join Zoom. And we understood that. I mean, I even have some patients who don't have internet, but yet has a phone, they can call. And so we actually do telemedicine in using all those avenues. And basically we communicate. Now, it's not the same thing, clearly, right? Because there's something about having that personal touch. There's something about looking at my patient physically. And there are questions I don't have to ask because I know. And so that was the difficult part for me as a physician that really focused on providing the quality care to my patients that was missing. And how do I replace that? So, conversations that would take 30 minutes is now taking 45 minutes, And so we had a lot of conversations. So, it's great. And it was hard to get things going because, getting used to just talking to people on the phone and coordinating that sense was not always familiar to folks who are not used to telemedicine. So we had to do a lot of education around that. But for the most part, it was a very successful strategy that reduced transmission and keeping our staff safe.
Right. Let me just go back to something that you had said earlier. You talked about the rumors and everything that would be coming out as a result of COVID-19. What are some of the biggest rumors? What are the top 3, top 5 things about COVID that are just big rumors that maybe we here in the forum should know?
And there's a lot. You pick it. And I'm sure everyone here in the forum probably have their own rumors that they've heard of. But for us, I'm Haitian descent. My parents are Haitian. And I was born in Brooklyn, New York, just to give you a background of me. So in the Haitian community, right. In the Haitian community, there's a lot of rumors there that I had to debunk as a physician. I felt that it was my responsibility to take onto some social media platforms, et cetera, to educate my community. And surprisingly, by doing that, I realized everyone had also misinformation and rumors as well about what this virus happened. So one example, for instance, can Black people get this virus, right? That happened early on. That was something that was debunked, obviously, early when we started seeing that not only we can get it, but it's actually impacting us more and much worse. Another type of rumor that we've heard is that heat can kill the virus. So being out in the sun, et cetera, can kill the virus, right? The third thing, which is very important, and I actually made a point to actually talk about this in all of my platforms, is that because you're Black, you are going to get this virus. That's a myth. Your race, your culture has nothing to do with the fact that you're either going to get infected by this virus or this virus is going to kill you. The thing that's actually the culprit of why you get infected by this virus, or why our group get infected by this virus more, is because when you think about essential workers, we overwhelmingly represent, meaning the Black and brown community, we overwhelmingly represent people in the front lines in these essential workers. So as you know, Mr. Scott, the folks in your city that's working very hard, small businesses in the front lines that were deemed essential, they look like you and I. And so that is probably why a lot of them were getting more infected. And that's why you see infection rate, like in New York City, was higher among those population. The second thing is that same population has been dealing with health disparities for a long time, for decades. And I am saddened to say that as long as we knew about health disparities, and the US government is making effort in documenting when health disparities occur, but we have not made any true efforts in addressing the issues, closing the gap. In fact, the same level of health disparities that existed 10 years ago still exists today. And what I mean by that is that people with diabetes, hypertension, heart disease, the issues is that our community don't have the access that they deserve. And number two, they don't have the experience of care that they deserve. That means the quality of care that they need, right? Because is that Black man who walks into that doctor's office is going to get the same services as a counterpart, such as a white man that would walk into the office in the same doctor's office? Are they treated the same? Are they going to get offered the same therapeutic measures? So that is real. And we already know that it's not true. They don't get the same service and they don't get treated the same way. And so those health disparities predated COVID. And because of those disparities, COVID-19 has now shined a light on the gaps. And I didn't want people in our community and around the country to think that it's because of the color of our skin is putting us at risk. That's not why. It's unfair inequality, injustice that happened in our society and that continues to happen that puts us at risk, and why we are dealing with COVID-19 right now.
Great. Oh, that was a good thing. That's your top. That's your top five.
Well, there's a lot more, but I don't think we have enough time to talk about all the myths. But there's a lot more.
Yeah, I wanted to recognize. I wanted to recognize Commissioner Smith, who has since joined the forum. Commissioner Smith, as we mentioned to everyone before, what we did because of photobomb is that we have actually muted everyone. So if someone wants to ask a question, they just need to put their hands up or to hit the thumbs up button, and we'll we'll recognize you and make sure something that your question is answered. And for everyone else who joined after I made that statement, by the way, just put your hands up and then we'll ask the doctor a question. There's a question that just came in that said, why does COVID affect us differently? And I know you spoke about the health disparities, but specifically, some get infected and are asymptomatic and some get severely ill. Why would that be?
So the science behind viral illness really doesn't change. The virus that we're dealing with, the virus that we started with in December in Wuhan, China, is still the same virus. It's still a coronavirus. We call it a coronavirus because the virus is shaped like a crown, okay? Yeah. And that's why we call it a coronavirus. So most viruses, as we know, when they infect the body, we go through these illnesses, right? And the illness, essentially, we all recover. And it's a limited illness, and you'll get sick for a week or two, and you would recover. Most people recover, as you're hearing. But this particular virus, which we call the COVID-19 strand, is very interesting because, number one, its transmissibility is very high. That means that people can easily get that. And we didn't expect that. And in fact, it's when we knew that the outbreak in Wuhan, China, quickly became a pandemic, an epidemic there, that's when we knew that this thing was traveling fast and spreading quickly. And before you know it, by March, it was a pandemic. So that means the virus was in most places around the world. So again, its transmissibility is very unique, and it's something we're paying attention to here in the healthcare industry. Number two, its virulence. That means its ability to cause disease and acute illness. This virus in particular causes severe inflammatory process in our body that you all probably heard of. Is called the cytokine response. And those inflammatory responses can end up overwhelming different organs. And in this particular case of the coronavirus COVID-19, the one particular organ that we're concerned about is the lung. And this is why most people, when they develop shortness of breath, they've moved from moderate infection to severe infection, and they need to go to the hospital right away to get oxygen, right? And so that's what that happens. So now, why do the disease cause mild illness? Again, most people eventually will get a virus and recover. And this is that's not unique to coronavirus per se. The flu virus is very similar, that you can find people who are asymptomatic. So I hope that answers that question. But just to keep in mind, there is a mild infection where you just get mild symptoms. There is moderate infection where you get flu-like symptoms, and you would essentially, be sick for about a week. You get a cough, sneezing, we call this rhinorrhea. Cough, shortness of breath is the symptom that we pay attention to that will then tell us that you need to go to the hospital. And at that point, you'll have severe illness. And severe illness, treating people with severe illness in the hospital was very interesting for us because, as you know, there's no real treatment for a virus. And so we're looking for means to improve the person's ability to somehow fight off the virus on their own. So we're supporting the body to go through this process of fighting this virus. And yes, we have been doing a lot of experimental drugs in the hospital. And I just want to just digress a little bit. The experimental drugs that we've been using in the hospital was because we were dealing with, number one, the fact that the urgency of us finding a solution, and number two, the fact that we got to make sure that we give people quality and evidence-based no matter what. And so the FDA have approved us to use different type of experimental medications that we've learned from data from China for us to be able to see if this is something that can provide someone support. As you all heard, some medications that we actually thought was effective, we now know not only is not effective, but actually cause harm. And so, we're under a microscope. Medicine is under a microscope now because this is the first time in a long time, I would say, that our society is actually looking at how healthcare evolves, how we respond, the gaps that we currently have that we've had a long time in our healthcare system, the imperfectness of medicine, right? Because that's why we call it an art, right? Because we need to learn and understand what we're dealing with. And so I think it's an interesting time, Mr. Scott. And so I hope I answered that question, but also I just want to say that it's an interesting time that we all have to work together and really understand what we're seeing, and not too quick to criticize, but more so to say, look, we got to work together until we find a solution for this.
Great. Thank you, Dr. Coupe. I think I saw Trish's hand was up. So Trish has a question.
Yes, yes, sir. I would like to ask you a question. If a person has already had it and they are now free of it, are they still carrying anything that could infect someone else?
Great question. Great question. So we know that if somebody gets infected by the coronavirus, the COVID-19, you can be tested for that on day 1. Day 0 to day 7 is when the virus is highly transmissible. That means you can pass it along to anyone. The first 7 days, essentially, is when you are contagious. Then the following 7 days, the virus still hangs around, and that's when the illness is what you're dealing with at that moment in time. We keep people in isolation until they feel better. Even when your symptoms go away, the virus can be detected in your body up to almost a month later. So you can be tested for the virus, positive for the antigen, that is, day 0 all the way up to 30 days. You can do the antigen PCR testing, the nasal swab. We can even do stool testing to see that you have the virus. But once someone has recovered from the virus and they are no longer symptomatic, they're probably not likely to be contagious and pass it along to someone close by to them. And if they do pass the virus at that time won't be as virulent, meaning it won't be the same strand and it won't have the same impact on your body as if you had contacted the virus from them the first 7 days. That's when the virus is most virulent. Now, with that being said, I've discharged a lot of people with the COVID-19 virus that went home from the hospital. I have isolated a lot of people from our office at home with the virus, and some of them has been beyond 30 days, and they're still doing the same public health measures at home, keeping safe, washing their hands, etc. Because remember, we have a lot of other viruses, not just COVID-19. And so those people so far, as I am monitoring them still, has not been reinfected. Okay, so it goes along with what we believe is that if you are infected with the virus, you can't get reinfected. And number two, so far, those folks that I'm monitoring has not yet transmitted the virus to any of their family members. In fact, when they are infected, most likely all their other family members were already infected or also infected at the same time. And so, but I have not gotten any reports that the folks who recovered, who are home now from the hospital, who have spent more than 30 days out of the hospital from being sick, have transmitted the disease to anybody, nor have I heard that they got reinfected, which we believe is very unlikely.
Okay, very good. I'm not sure if did I see Commissioner Smith's hand up?
No,
Sharon,
my hand, but I really want to thank him, not only for enlightening our public, but for being in the front of this. The knowledge seems to be, 10 minutes ahead. And that, as the public, is really what we need, because we on the news keep getting a change of knowledge. So I wonder, how often are you updated on the latest? And thank you again for sharing all your wealth of information with our public.
Thank you for that, and thank you for that acknowledgement. It's always good to hear that from people in our community, and that support is much needed. So thank you for that acknowledgement. Now, as I mentioned earlier, when we think about the current pandemic in which we're in, I would think the last pandemic we've all experienced probably was in 1918. And I know we think about the pandemic in 1950s and 1960s, there was a flu epidemic then too, but not too many of us in our society currently have lived through a pandemic. And so for a lot of us, this is our first true pandemic that we're living through. Yes, I've been monitoring the situation in Wuhan, China, as well as in Italy, as well as Iran, as early as in January. We've been monitoring it. Part of it is because of my field, my profession. Infectious disease is something that is something that I need to always stay abreast on. Yes, I've also been following what the CDC is saying, but more importantly, I've been following more of what WHO has been doing. The World Health Organization is an organization that I personally respect, has a lot of great professionals. Some of them are my colleagues. I know some of them personally there. And they've been doing work in many different countries for decades. And so they have a lot of information, a lot of experience. And I'm someone who respects experience more so than just knowledge or opinions. I respect experiences. And so they have a lot of experience. And so as they were experiencing the outbreak in Wuhan, China, I too was getting information from them, reviewing data. And I like to say data because we don't want to call them studies, because I guess a lot of people criticize the way the studies, et cetera, were done. But we were just looking at raw data, people who were getting sick. Were there biopsies done of people who passed away? Did anyone did an autopsy? Those type of things I was following as early as January, just to understand this new strand of coronavirus. Once late in January and February, when we knew that it became a widely spread epidemic, impacting not just China, but most of Europe, we knew that this was going to be a matter of time it hits the United States. Since then, I've been in close communication with my colleagues at University of Michigan, Michigan State, NYU. One of the things I have to say, I'm well connected with folks in multiple locations just to get a sense of their perspective and their experiences and what they're seeing. And those are really most of the areas in which I remain getting the source of information about this virus. And obviously, up until, for us, March 30th, when we first saw in our office infected individual in our office. In the hospital, obviously, was a little bit early on, but it was March 30th in our office, we saw the first infected person. And since then, I've been monitoring those information. I've been asking my patients who are infected with COVID-19. We've been asking them about their symptoms. We've been asking about all of the other conditions that they're dealing with and how that the COVID-19 impacted them. So, as an internal medicine physician who has a public health background, who also have a health policy and a health services research background, I have the ability to now look at the experiences that we're seeing in our community to be able to provide the care that our people deserve, and not the care that we are hearing in the news, or the care that, and excuse the expression, but whether if it's CNN or whether if it's Fox, these physicians, obviously they have their own expertise, but they're not in our community. So our unique needs will not be addressed by listening to only CNN or Fox. And part of my education communication to my patients and to the folks in our community is that Dr. Fauci is not your doctor. So if you have a problem, a medical problem, you need to reach out to your doctor, not to listen what you hear in the news and then try and recreate that yourself without actually having an advice by your physician. So again, great question. I think we all are learning about this virus, and whether you're a healthcare professional or not, you have access to CDC, you have access to WHO, and I depend on my community as much as my community depends on me to get the right information on what's going on.
And Dr. Coupe, thank you so much. We're down to a minute. I have one quick question for you. We have to see how we can frame that into a 10-second response. Gotcha. Is there a COVID-20 out there?
Probably.
Okay, probably. Yeah. That's good. That's just setting us up for a repeat or for a follow-up call from you. Dr. Coupe, thank you so much for being on here with us each day, and you're going to help, you're going to share a part of this. We have inched up in terms of our response for the census. We're up to 52.5 now. We're inching along. I heard some numbers yesterday, like our coastal communities are in the 30s instead of their in reference to their response to the census. So North Miami Beach, you're 52.5, but we need to get this going a little bit more. Every single digit counts, but it's going up. So that's a good thing. Dr. Coupe, this evening also, we have Bon Bagay, which was going to be a forum that we have in honor of Haitian American Month. And it's going to be this evening from 7 to 8:30. Because of time, I can just tell you, go to nmb.gov and you will see citynmb.com and citynmb.com, and then you'll be able to see what's actually going on this evening. We have 5 great panelists in different sectors of the Haitian community who will be speaking to us this evening. And it's from 7 to 8:30. Please go to our website. The event is Bon Bagay in celebration of Haitian. Thank you so much for being with us, Dr. Coupe. We look forward to you being back. Take care of yourselves, NMB, and be safe. Bye-bye.
Thank you so much. Bye-bye, everyone.
Thank you, sir.
Bye-bye. Thank you.